All right, let's jump right into it. If you're a medical trainee, you know hepatorenal syndrome, or HRS, can feel like one of the most confusing things you'll see on the wards. You've got a really sick liver, and all of a sudden, it seems to be taking the kidneys down with it. Getting a handle on this is an absolute game changer. So let's break it all down. So imagine this. You're on call, it's the middle of the night, and you get a critical lab value for your patient with cirrhosis. Their creatinine just shot up from 1.0 to 2.5. Whoa, is this a brand new kidney problem? Did something you do cause this? This scenario is a classic, and honestly, a pretty terrifying moment. What you do next really matters, and it all starts with figuring out what's actually happening under the hood. To solve this mystery, we've got to understand the crime. How in the world does a sick liver pull off a kidney shutdown? You can think of it like this elaborate, systemic heist, and understanding the plan is the only way we're going to stop it. And this isn't just for exams. This is the key to every single diagnostic and treatment decision you're about to make. The mastermind of this whole operation, it's portal hypertension. That's just a fancy way of saying the scarring in the liver has created this massive pressure backup in all the veins that feed it. The body has to adapt, and it does something pretty drastic. It throws open the floodgates on the blood vessels in the gut, what we call the splanchnic circulation. It's like opening up this huge new reservoir for blood to just pool in, pulling it away from everywhere else. And this slide just lays out the domino effect perfectly. So with all that blood just hanging out in the gut, the rest of your circulatory system thinks it's running on empty. This is what we call effective arterial underfilling. The body, it panics, it sounds the alarm, activating all these super powerful vasoconstrictor systems to try and clamp down and get the blood pressure back up. But the kidneys? Man, the kidneys get the absolute worst of it. They get clamped down so hard that they're basically starved of blood flow. So here it is, the single most important takeaway. The kidneys themselves are innocent. They're just the victims in this whole mess. If you could take them out and look at them, they'd look totally fine. They're just not getting the blood they need to do their job. And that's exactly why we call HRS a functional renal failure. The hardware is fine, it's the supply chain that's completely broken.
Okay, so now that we've got the why down, we can put on our detective hats. How do we prove that it's hepatorenal syndrome acute kidney injury, or HRS-AKI, and not get fooled by an imposter?
First things first, we have to be sure it's actually an acute kidney injury. And for patients with cirrhosis, the definition is really specific. See, their muscle mass is often low, so their baseline creatinine can be super low to begin with, making you think everything's okay. A jump of just 0.3 can be a massive red flag. This is why you absolutely have to know your patient's baseline creatinine. So this is your playbook. The key thing to remember is that HRS is a diagnosis of exclusion. You have to prove it's not something else first. So what do? You stop the diuretics, maybe they're just dehydrated. You give them a big volume challenge with albumin to see if the kidneys wake up. You make sure they're not in shock. You stop any drugs that could be hurting the kidneys. And only after you've ruled all that other stuff out can you confidently say, yep, this is HRS. Now, the biggest lookalike, the one that trips everyone up, is acute tubular necrosis, or ATN. That's where there's actual structural damage to the kidney. A huge clue is in the urine. With HRS, the urine sediment is usually clean or bland, but with ATN, you get those classic muddy brown casts. I like to think of HRS as pre-renal on steroids. It's a super severe functional problem that, and this is crucial, just might respond to our treatments, which ATN won't.
All right, so we've cracked the case, we've made the diagnosis. Now what do we do? How do we fight back? The goal here is to reverse that crazy renal vasoconstriction and get blood flowing to the kidneys again.
Well, the treatment is actually pretty clever because it directly targets the pathophysiology we just talked about. It's a 1-2 punch. First, we use really potent vasoconstrictors like terlipressin. Now, I know that sounds weird, right? Why squeeze the blood vessels when the kidneys are already squeezed? Well, these drugs work on the whole system to counteract that massive vasodilation in the gut, basically forcing blood back into the main circulation. And second, we give a ton of albumin to expand the plasma volume, making sure there's enough fluid in the tank to go around. Now, we have to be realistic here. Even with our best evidence-based therapies, we see a reversal of HRS-AKI in only about half of patients. It's basically a coin flip. And while that's a huge leap forward from where we used to be, it tells you that, sometimes this medical therapy just isn't enough. And there are some pretty clear rules of engagement. You give the therapy a fair shot, up to 2 weeks. but you also have to know when to call it quits. If you've thrown everything at them for about 4 days and you see zero improvement in kidney function, it's probably not going to work, and it's time to stop the treatment. And all of this leads us to the endgame, because even when our medicines work, it's not a permanent solution. We have to go after the root of the problem.
I love this phrase. It perfectly captures what we're doing. These powerful drugs, they're a bridge. They're a way to get a desperately sick patient from one side of the river to the other, where the definitive therapy is waiting. They buy us precious time, but they don't fix the underlying disease.
And that definitive therapy is a liver transplant. There's no other way around it. Why? Well, because it's the only thing that actually fixes the portal hypertension that kicked this whole mess off. A new liver restores normal circulation, gets blood flowing back to the kidneys, and, importantly, prevents this from ever happening again. Seeing HRS-AKI is a giant red flag that a patient's liver disease is at the end of the line, and their short-term mortality is incredibly high without a transplant. So I'll leave you with this to think about on your next shift. We decide who gets a liver transplant largely based on their MELD score, and creatinine is a huge part of that score. Now, if our treatments get really good at reversing HRS and lowering that creatinine, we are also lowering their MELD score. So here's the question. Does that actually make them less sick? Or are we just masking how severe their liver disease really is, and in the process, making it harder for them to get the life-saving transplant they desperately need? It's a tough medical and ethical problem, and one we're going to be facing a lot more.